to the Weekly Huddle. Today we are in episode 101. I am Dr. Praneeth Palamuri. I am a cardiologist working at Care Hospital, Banjara Hills. I am joined by my co-host, Dr. Anoop Agrawal, who is also a cardiologist working with me at the same place. Most of you are regular attendees, so you know the format of Weekly Huddle. We try to discuss about various topics which affect our medical practice and equally involves not only doctors but other people who are involved in patient care, be it nurses, technicians, paramedical staff. We normally take a clinical case and sometimes we also discuss a non-clinical case as well, which is pertinent to the practice as I mentioned. Today we want to discuss a not so clinical case but which is equally relevant in medical practice or which comes up as a part of the medical practice on uh, patient affiliation bar care beyond hospital. Everybody treats patients and sometimes we do get involved with patients in terms of their personal history, and this kind of goes beyond hospital where you are expected or you are requested to accommodate inpatient management equally in situations other than patient management beyond hospital. So how do we talk to, or how do we present ourselves in these situations, something that we want to discuss today. I start with a case, take opinion from Anoop and probably share or let to know about how others think or feel, and equally let know about what is their personal experience on these situations. So Anup, I'll about to discuss about one of these experiences which I had. This patient is an 84-year-old male who is hypertensive and diabetic, who also had an ischemic heart disease. He underwent bypass surgery 15 years back. He was in functional class 2. For the last few years, he was gradually deteriorating. I believe I've been following him for the last 5 years. That is where I acquired this patient, and essentially, I was managing him for his heart failure, which he was having. The LV function was severe, and he was in functional class 2 and essentially managing the medication. And during these last 5 years that I have known this patient, he had 2 3 hospitalizations, and for the last 1 year he had 3 heart failure hospitalizations. And you could see that the age was equally catching up and probably the disease was progressing, and he was kind of on an deteriorating course. And I think both the patient and the family know about the overall prognosis being poor, and the expectations were pretty much set to both the patient and family. Now, this last heart failure hospitalization happened about 3 months back, and this time this patient kind of got stabilized after a bit of a prolonged course, close to 2 weeks of hospital stay, and finally he could make it in a kind of an weak state, and then he got discharged with the medication. Because of his frequent hospitalization, I also asked this patient to be on close follow-up, because the goal right now is to prevent any heart failure hospitalization, and whatever expected lifespan that this patient has, we want to have a better quality of life, and prevent an heart failure hospitalization is the primary goal. And now, understanding that his frail condition and his overall general condition, the hospital follow-up was not happening, and his son apparently messaged me about his overall general condition being poor and the possibility of bringing his father to hospital being difficult. And he tried to update his overall condition on phone with the assessment that he could do. And at the end, he equally requested that because it is too difficult for him to bring the patient to hospital, can you come to hospital and do a home visit? So that was the question that has been asked to me. So that is the problem that equally I had. And the question that I had is whether I should join or whether I should go home and do a home visit. And if I have to do a home visit, what are the things that I should do? Whether I will be doing the justice on doing home visit, and without the armamentarium available in hospital, how much can I be helpful? And second thing, when patients are being followed for that long, we kind of get attached to patient family, or at least I've been attached to few of my patients when they are on long follow. And the question that comes is, when patients get followed up, how much is our thought process going to get biased? Do we get emotionally attached and our thought process going to change, and we will be in a position to make the rational decision which is important for the patient? And what are the do's and don'ts? Is how far is too far? How that we should get involved in this patient care beyond hospital settings, and any tips and tricks that we have to follow while we are doing, and how do we satisfy the patient expectations sometimes, which may look out of the box for you, but for patient it may be normal for them. So these are the kind of questions. So these are these unusual situations that we encounter. So I know there is no science about this topic, but I wanted to know how do we deal each and every individual, or each and every doctor will have its own situations that they have encountered, and probably some things that we need to learn from each other. And if there is any science behind it, probably, or any legal issues that we probably should know, is the topic of discussion today. So Anup, this is the case that I have, and if you were in this position and if you are expected to do a home visit to see the patient, would you go? And if you do not go, how do you say, and how do you say no without breaking the ties? And if you go, what do you do? And all those questions which I asked, over to you. How do you approach or see this patient?
So, Praneeth, what the case that you put up today and the whole idea of our discussion is not very unusual. Of course, we keep our doors and windows closed for most of the patients. So, majority of the patient who actually want something like this, they don't speak up because they don't think something like this is even possible. Those who speak up, those are the one who either have set very high expectations, or those who have had a reasonable affiliation with us and they would like to use that affiliation to extend these kind of services. I personally believe that treating physicians going to the patient's house once a while to take care of the patient in genuine situation is not a bad idea. It's actually something which what we would call it as a continuum of care, and wouldn't necessarily be a bad idea. But I will tell you my aspects of doing this, and the decisions that I would make based upon the factors that I'm telling you. So very early on when I came back to India, I had a similar thought process, and I actually wanted to start a setup where I would do uh, not necessarily a home visit, but kind of a semi home visit where I can go to the community, either to managed houses or something of that sort, where I come close to them rather than they coming to me. I would charge a premium, I'll charge for my time and all this, but the idea being those patients who find it difficult to come to the hospital, they can come and see me there itself. And of course, you know this very well that we are young cardiologists in our field. So we don't have that marquee status with our name or with our work that some of our colleagues have, because they have worked for over the past so many years. So lot of what we do is also optics. Lot of what we do is also we need to make sure that patient perceive us as quote unquote big doctor or important doctors or somebody who is worth their time. So when I shared my idea with some of my colleagues around me, the most common, I wouldn't say 100%, but the most common answer that I got was that doctors who go to the community, they typically have a lot of time, and community typically do not appreciate those doctors who have got a lot of time. You need to be a little bit busy, or at least pretend to be a little bit busy, so that community appreciates or community values your time or your presence and whatnot. AKA, big doctors don't make home visit. That is the basic idea of what this was. I obviously did not execute it, otherwise you would know it by now. That is one aspect whenever I'm looking at the home visit scenario. That was a general thing. But it does extend to the patient scenario that you are bringing up, and these are the kind of patients who would benefit a lot from a direct doctor visit, and they are the one who find it very difficult to reach to the hospital, and in a sense they often present to the emergency room rather than to the OPD. So they are the one who will benefit the most from it. The second issue that I often struggle with is, if I do go and make home visit, do I have the necessary equipment or ancillary services that I can use to help make a decision? Me being a cardiologist, particularly an intensive care cardiologist, I do need certain equipment to help myself make a decision. Whether a portable echo is something that we should have, whether ECGs are something that we should have. Of course, the blood pressure equipment and the old school stethoscope is something that we can carry. There is no doubts about it. But weighing machine and all those kind of things, which family may or may not have. So that is another thing which I often ask whenever I plan to go for a home visit. And then the third thing is, if I am talking about a home visit, then uh, by default, in cases like yours, I am a little bit more involved with the patient. So at what point my professional decision will turn into more of an emotional decision, where I'll be making discounts, where I will be making compromises just for the fact that I am at home. Like, for example, if a patient comes to the hospital, the threshold of you ordering a test is much lower than what it is when you are visiting at home. So will you be also caught into that kind of thought process, saying that, okay, you are at home, why to unnecessarily order an x-ray, let us manage without an x-ray? Versus if the patient was in the OPD, you will have a much lesser threshold to do the necessary investigations as and when required. And a lot of these complex patients, they do require some assistance other than the usual vital assessment and whatnot. And then whether we invite a slippery slope kind of phenomena, where we entertain request on one aspect, whether that request extends to things which aren't necessarily clinically driven, but more of a convenience. After all, a doctor visiting to your house is far more convenient than you visiting a doctor's appointment. So I think a lot of these things, they do come to making a decision. I must I must confide that I have personally made a few home visits since I came to Hyderabad and since I have started my practice. I once make sure that those home visits are not charged, as in I don't charge any fee for that, because I want to make sure that I'm doing that out of my concern rather than any kind of prescription or whatsoever. The legal aspect of it, whatever prescription I write, whether that is valid or not, that I don't know, and probably we learn from our colleagues that whether that is acceptable or not. But I have also made sure that I do not visit the same patient again at home. Whether that is right or wrong, again, I don't know. But I have not done that. One of the questions that also came to my mind is, if patients do benefit from a home visit, and if I personally do not want to do for whatever weird reasons, can I ask my teammate or a junior or somebody who can go and act as a surrogate for myself? What I realized is, a lot of these patients, they are very complex in nature, and many of the times I may not even believe or trust what my juniors or my colleagues' assessment, and I may end up making even more compromises by doing so. So at least so far, I have not sent any of my colleague or junior as my surrogate when I go and see these kind of patients. So these are some of the thought process that I have in my mind. Of course, the whole background, Praneeth, the way I understand the whole background is in India, our in hospital or our hospital programs, they have a little bit of structure. Now, from the global standard, one can argue that we probably don't have structure inside the hospital as well. But at least we have some structure. We have few things in place, how we treat patient, how patients come, how what they do, and all those kind of things. But unfortunately, we don't have any clinical care structure outside the hospital. That is where we lack the most. The so-called home care is in its infancy at the best. For most part, it is not available, and even where there is available, the available staff is mediocre at the best, and there is no structured way by which patients can be taken care of, like a nursing home visit or a nursing phone call, or those kind of things are not really standardized. Even a mid-level provider who can act as a surrogate and make frequent visits, even those are not very standardized. So we are trying to discuss something where can we fill this so-called a well-established home care program in a lot of countries which already have, and I don't think we will be able to do that for our own logistic reasons. If our day typically ends at 6 or 7 p.m., it will be very impractical for us to implement this on a more routine basis. And making exceptions to like the one in your case can be taken on a case by case basis. I can count how many times I have done in my last 4 years. And I'm pretty sure even those one of us who are willing to do it wouldn't be doing it more than a year, more than once or twice a year or so. So in your particular patient, I think going once is okay, but I would like to devise some sort of structure in their clinical care, either through a nursing home visit or a mid-level home visit, so that we can find a way by which we can provide care to this patient. Me visiting home once is not going to solve that problem. But at the same time, I don't mind going and visiting once. The last point which I also want to mention is the safety and comfort part of it. We are assuming that the providers are going to be males, but the same thing is going to extend for females as well, and also for male to certain extent as well, that when you are going and making visit, you will most likely be making visit in off hours, either very early morning or very late in the evening. And how to ensure your safety and comfort, both of them are going to be equally relevant in this particular scenario. While safety may not be an issue every single time, but comfort will become an issue, because at some point you do want whatever work you are doing, you need to be comfortable in what you are doing, and that also is something which needs to be taken into account when we are talking about home care. So that was my thought, Praneeth, and we can take our colleagues' opinions as well.
Yeah, most of the points that you mentioned, I completely agree, and I hear what you are saying. The point that you mentioned is when you are busy, at the same time, when you are concerned about the patient, and you know, the thing that you mentioned is instead of you, can we send someone from your team as a surrogate to look into it? And that also is commonly done. Either you are junior consultant or sometimes a nurse. We have Salma, who is a heart failure nurse. Salma, I believe you will be equally involved in patients, particularly enrolling them for transplant. I believe you will be could have been closely attached with one of the patient. At least I can remember one patient whom we both associated. So I'm sure you might have also encountered the situation where you would have got requests which were out of your job profile or out of the common things that you look into it. And if there were these unusual requests, how would you approach, and what is your overall thought process on these kind of situations? Salma.
Yes, sir. As you said, you are very rightly, we were associated in one patient care who was, long patient of heart failure clinic, kind of have been with other unit also, and then moved to Banjara unit only because I was shifted here, and that offended the doctor a little, but somehow they managed to go there, and then they used to come to me for the extended care that they could get, and the faith or comfort that they could find in my presence. So that was one. And in fact, in recent times also, there was another patient. I cannot mention name and the consultant, but yes, in fact, they wanted me not exactly home care, but when they were going to other unit, they requested that if I can join them, because one reason was that his wife was from a very illiterate background and couldn't understand the perspective, and there was nobody else to take care. So one of our doctors, in fact, gave me idea that you can adapt this as your extended service, and have a plan of action for your services being charged, etc., which is again a second point. But what happens is, everywhere when you have such connected patients, and might be because our atmosphere is like that, we go a little beyond. But as Anoop sir was saying, having that in a consistent format would be really very difficult. And yes, there will be times and days there where you won't be able to present everywhere, and it becomes difficult to tell them that I cannot do this. So having a bar where we can define it is not possible, because one thing, we don't have any legal this thing, definition of it, and the second part is your work schedule is not defined. So they expect you to be available anytime, every time, which will be difficult because you are again obliged to your regular duties. So that would be really very difficult. But yes, we did practice this in the early days when we were having HF clinic. Of course, I couldn't go because I had my own reasons. My kids were very young, and I could spare that time. And as Anoop said, regarding the safety, which becomes again primary component for especially people if like the staff is at hostel, they have to get that extra permission going out of the times. So for that we always have to have one male person accompanying, but that idea couldn't run for whatever logistic reason. So having once in a blue moon visit, or in real emergencies where you don't have really anybody and the patient really needs you, I wouldn't mind going in my own perspective. But
Salma, we lost you. Salma, you are muted.
am I audible now, sir?
Yeah, you are audible now.
Yes. So for long run, that might not be possible. You can do it for one or the other patient, but again, it gives you that feeling that you are becoming biased. So even if you want to do it in an extended run, it won't be successful program unless it is established some center, or some person who are associated with you, or if some has his own defined team who is like going for it. Only then it would be a real official idea. But again, things which come easy are always taken for granted. I don't know how much patient will have that faith in you when you are doing it, unless there are other person is that capable of analyzing you or understanding you or has faith in you.
Yeah, so I get your point of taken for granted as well, and I will come back to you after that. I want to take a few more opinions on various aspects of healthcare. We have Swapna as well. Swapna is a physician assistant. So Swapna, as a physician assistant, can you share about your experience or your thoughts on these situations? I'm sure you might have also encountered these situations. So how do you deal, and what is your thought process on this?
Good evening, sir. Sir, I'm mainly involved at discharge process, discharge time, and in the outpatient clinic too. So what I do is, as everyone does, I educate the patient as well as the attender who always stays with the patient to monitor. I'll ask them to buy a BP apparatus, digital, where you can measure heart rate, blood pressure, saturation, and everyday intake output chart and body weight. This is a mandatory. They have to measure every day for all heart failure patients. And I'll educate them that if there is any little increase in body weight, when to approach the doctor. and how to monitor. All those primary things I educate to the patient and the attenders, sir, because most of our patients are within Hyderabad and some are in the peripheries too. And we provide a on-duty mobile where at least in emergencies they can approach the thing and they can take online opinions. And in emergency, I'll always say, please go to the nearest hospital and then inform us. I mean, we should not delay in timing, wasting, getting appointment or reaching only our hospital like that. Hello.
Yes, Swapna, I get what you are saying. So your point of educating the patient where they do not expect you to come, but you are equally educating them so that they know what to do. But oftentimes, what we understand is patients are either misinformed or they do not understand, or even though they understand, they are not comfortable or confident, and they still want some kind of a confirmation or some backup where they want to be sure that they are doing it right, and that is where they want people to be around. And sometimes that expectations of somebody coming in and kind of hand holding and inpatient care is expected, and that is where when they ask you to kind of stretch yourself out of your boundary, and the request is, if I can you please pay a visit to my home and teach me what all you have said, I kind of not able to do. And if that situation or request arises, how do you handle is the question that is there. So Swapna, did you encounter any of those situations where you are asked to pay a home visit? Swapna, are you there?
Can you hear me, sir?
Yeah, now I can hear you.
Sir, there are, sir, 2-3 cases, not very recently, but about 3 years ago, 2-3 cases where I did home visit within Banjara Hills, where there was an elderly couple, very elderly couple, where the transportation was very difficult. Even mobility from first floor to ground floor was very difficult. There was no lift. In such cases, yes, I did home visits, sir, twice with on-duty doctor accompanying.
Okay.
Hello.
So yes, Swapna, thank you. So I understand that most of them are accommodative, where when the patients are requesting, and when we believe that the reason is genuine and when they need help. So irrespective of the hierarchical system of the healthcare, I believe most of them are accommodative for their patients. I will move on. Thank you, Swapna, for your sharing your comments. I'll come to Dr. Shankar. Shankar sir, I believe you practice it. I would say a bit away from the city, and when we go far away from the center of the city, the doctors are even more respected, or they are part of family. You are expected as a kind of treated like a god, if I have to use layman terms, and the onus or responsibility on you will be even much higher. And obviously, the unusual requests are also quite common than what we get here. So if these situations, I'm sure you might have encountered. So what is your take on these situations, and how do you accommodate, and how far you go, and tips and tricks on managing these situations? Shankar sir.
Good evening to all. My heartily congrats to Dr. Praneeth and Dr. Anoop for this 101 huddle session. Successfully completed the century. Congrats for the same. So, Vaidyo Narayano Hari, our epics told. So, doctor is next to God, and doctor himself is a God, or next to God, are demigods. So that type of respect was given in the society to the doctors. But look at the image today. See, rivalry against doctors at every level of society. Added to that, professional jealousy, egoism, and commercialization. All these have ruined our image in the society. So to build up our image in the society, we should work hard and serve more. And our epics and Vedas tell, Aptopaseve bhavatu arogyam. Treat everyone as your near and dear. This was accepted by our predecessors, and we were honored by the society, and our image was at a high level earlier. But now I'm very sorry to say, because even in spite of doing my 40 years of service in this area, what I got respect in the early years has almost slowly it is coming down. So this is for many reasons. I need not go into the details, but I personally, I did house visits, and I'm doing also now house visits. So house visits, earlier when I was initial days of my practice, I was a little free. I used to have many house visits. As I became busy, they started asking me to come to their house, and slowly somehow they managed to come to hospital to get checked up by me. But that was so. Even in our area, see, ultimately, dana moolam midam jagat. See, money plays a key role in the world. So, if a rich person is there, if anybody has got a power, either bureaucratic power or political power, we do visit them because of many reasons. But at the same time, with moral ethics, we were taught by our teachers like Dr. Professor S.R. Rao, Dr. Koppachi Krishnamurthy, Dr. B. Somrazu, sir, and Dr. Dayasagar Rao, sir, and many others. See, they are doyens and icons in the field of medicine. They are our mentors and guides. They have persistently insist on telling that physical examination and history gives more than 80% of diagnosis. Only 20% of investigations will help in supporting your diagnosis. So with this idea, I choose Jagityal, which was a town that time in the erstwhile Karimnagar district. Now it is a district headquarters. When I joined Jagityal, we were only 4-5 doctors. Now we are more than 150 doctors, 3 MRI scans, 6 CT scans, more than 10 laparoscopic centers, and 1 medical college in Jagityal. So now situation has become changed. So even the juniors have come. They may not insist me to visit their house, but those who have got, because I maintain good relations with the public, so if the genuine case is there, I do go and visit them. Having said that, the personal visit is a must, because the empathy, the sympathy, the charity, definitely it helps the professionalism of the doctor, and at the same time, it increases the image of doctors in the society. So when I visited their house, actually it was a little akin to Gajendra Moksham. Probably everybody knows that episode in Mahabhagavatam. So Vishnu Bhagavan, he descended onto the earth without any Shanka Chakra Gada. to save the elephant from the crocodile. So the same situation I also faced. So what else? Without any equipment, how can I test the patient? So I was having only stethoscope, and luckily I purchased a BPL ECG machine. That time it was only available in Chennai, not even in Hyderabad. In 1983, I'm telling. So with that two equipment, I used to go there. So now even the portable echo machines have come. So the smartphones have come. So little easier to even if we don't go, we can ask our assistants or juniors to visit them, and we can read those reports, and we can suggest the line of treatment. That may be possible with us at present. Recently, one of my teachers, Dr. Dayas Agrawal sir, asked me to see his regular patient. He is now 85 years old. So he is unable to travel now. He is almost confined to bed. So he complained of, the patient complained of shortness of breath. So he asked me to, Shankar, you go there and see what is the problem. He is ringing for many times today. Then I went, I obeyed my teacher's orders, and I went and saw. I took an ECG. The ECG was showing a left bundle branch block, where the age of the dates I not known, because earlier ECGs were normal. So we did troponin levels, and we did with the portable echo, we did echocardiogram. Then there was mild LV dysfunction, and we just increased, already was in diuretics, we increased it tarsimide 5 milligram. Patient was very happy. So this way, even just like Sri Ram and Ramabhakt Hanuman, we obey our teachers, and that was a type of the patient, the doctors, teachers, and students' relationship was there. Our teachers and ourselves, both of us maintained a rapport, vice versa. So coming to the second thing is the interested doctors, those who are interested in the social service, they can join some social organizations, charitable trusts, and they can provide service. And amongst ourselves, with the nurses, technicians, we can form some help groups, helping teams. Then we can provide this outpatient outside hospital care. And the third point I would like to enlighten, this COVID-19, really a pandemic, in difficult times, how to cope up with the patients. It has taught many lessons and avenues, how best we can satisfy our patients. But the only thing is, what we are lacking here is, at least the patients have a smartphone, with the telecommunication, with the teleconsultation, we can ask them their symptoms, and we can physical examination, if not really virtual, but virtual also, at least we can examine and we can advise them. Because after 40 years of my experience in the field of clinical medicine, ultimately I could realize we cure rarely, we comfort mostly, but we can console always. That is in our hands. We can at least console them. At least even though we don't have any equipment, or we don't interfere with the treatment also, we don't add any additional treatment also, but at least the consoling, the at the life end of life's end care, that is worth mentioning here. Lastly, the rehabilitation centers. There are many centers in Hyderabad. So as a step down care, so there we can provide the outside hospital care. Lastly, I recently I read in papers in Tulip Hospital in Sonipet in Haryana. So with the support of the Mindray IT Connect, so the Mindray, it provides all technology, technical equipment, monitors, ventilator, everything they will provide. And they got connected with the Tulip Hospital super specialists, and they are giving services at the remotest area, providing eICU care. So that is really it is worth mentioning here. So such advancements are there. So Dr. Somarazu sir, my senior mentor, my guide, my philosophy, everything is a philosopher. So he used to guide us when we were students in MD General Medicine. So how best we can provide the service to the patients by all these means. So I will be very happy if I get enlightened by Dr. Somarazu sir talk. Thank you, one and all.
Sir, before I let you go, I would like to get your comments on the other side of the picture, or other side of the coin, what Salma mentioned and what equally Anoop mentioned. Is what I understand is, as doctors, we are kind enough to extend our services to the needy patients, and various levels of hierarchy, everybody is willing to get to extend their personal time and provide services. But equally, as you said, the society is changing, the level of trust has come down, and people may not perceive in the way what we expect or what we deliver. And as few comments came in, anything that comes at free of cost is challenged or questioned, or it does not have any respect. And equally, one thing which has been extended, now people tend to take granted, and they try to abuse the service or the gesture that has been done. And as you rightly mentioned, without money, there is nothing in this world, and probably everything has to be monetized. But how to monetize, and should you monetize, and what is the silver line here where we can do it with it? So, what is your thought on this other side of the coin, sir?
See, that is there, but only thing is, if our behavior, everything counts. Our image in the society, the respect, our qualifications, our our clinical acumen, everything counts. So I don't think there will be any litigation unless any mal intention is there. Otherwise, I don't think. But only thing is, I say that the free service means only to needy people, those who really deserve. Apatradhanam, I don't accept. So there we should charge. That's why I told Dhanam Moolam Isam Jagat. Those the rich people and powered people, definitely we do, and for the it may be by ways, two ways. So I don't think the house visit actually at this juncture, most of the times there are many avenues are there, which I mentioned just now, 5 methods of giving this outside hospital care. So I'm very much happy with the house visits, and they respect me.
Yeah, thank you, sir. Is there anyone else who has any comments or any experiences to share before I go to Dr. Somraju, sir? Maybe I'll wait for 10 seconds for someone to share. Okay, so if there are no comments, then I'll come to Dr. Somraju, sir. I understand, being working with sir, that sir is a strong believer of providing care in hospital and equally beyond hospital. And while working with care, at least for few instances, I had to do home visits for a few of his patients, being a surrogate of Somraju sir, and I believe he believes in the concept of providing care beyond hospital. So, sir, we would love to hear about what are your thought process from the time that has been there when you have started practice and you have been seen the change in scenarios, and with current situation, how do you think these things are relevant, and how should we look into it in the future as well? So, over to you, sir.
Thank you, Praneeth, and thanks to all of you for enlightening some of the issues and some of the difficulties in providing continuity of care. The key issue is the continuity of care. Actually, looking back, when I started my career in medicine or cardiology in Hyderabad in 1978, for 1 year I didn't practice because I was not used to practice earlier. And slowly when I started, I used to have I used to go to a lot of home visits, and even in the old city. And some of the families still come to me, and their children, grandchildren now. And we always believed that continuity of care requires that you have to have people, if they're required to be visited by somebody, one of the members of the team, I will call it, in the healthcare delivery system. It may be, it need not always be a doctor. It can be a nurse or a physician assistant or any member of the team, part and parcel. The patient can be seen by one of them, and a junior resident or a senior resident or a consultant, anyone by rotation. In the last few years, at least twice, I made home visits, and patients are happy. And then we started this home care nearly 5 years ago in the name of Care Institute of Health Sciences, and some of you are aware of it. And COVID changed certain things that Shankar already pointed out. But COVID also brought out a very important concept of, say, online care. And now technology is evolving and evolved in such a way that online care is possible. And one of you mentioned the portable ultrasound machines, etc. I was using a portable echo machine for the last more than 15 years. And now I have a new machine by GE, and they are extremely helpful. And any member of the team can go there and transmit the images, and opinions can be taken. It's not essential that the teaching doctor has to go. Right from Nizam's Institute to now, we try to develop a model of a team of people taking care of patients. Initially, patients were not ready and public was not ready to accept it. But slowly they accepted the idea of team of people taking care and safety involved in it, and continuity of care is possible both in elective and emergency situations. And then the teaching doctor has to be kept in touch, and then they have to interact. the people who are doing it. And I'll only say, we used to have a saying earlier, some of you doubted whether patients accept it or not. The patient-centeredness, money is also talked about, but mind you, the philosophy of medicine insists that money has to be secondary. How all of us can make it happen as professionals or healthcare delivery teams now, I will call it. It's not just doctors, it's not nurses alone, and whole team, physician assistants and nutritionists and rest of the people, whoever is delivering the care, should have that patient-centeredness and making it happen to the patients. We used to have quote one interesting rule when a long time ago, when we were at Nizam's Institute. They say the rule is there are two rules. Number one, the boss is always right. And the rule two is, even if the boss is wrong, refer to rule number one. I'll now replace that word boss from the patients and patient's family. Be willing to tolerate and be willing to put up with it. And if you are not able to deal with them, ask one of your members of your team to deal with it, or ask another member of your team to take care of him. If you are not able to do it or they don't accept you, but patient is always right. Even if they are wrong, they are right. And if you have any of you have any questions, I will answer it. And home care, it is not just, I heard some of you talking as if we are inventing it. We are not inventing it. It's already there all the time. And Dr. Anoop will know. And now American Medical Association and medical education in the US now insists, and most of the hospitals now provide home care, and right from undergraduate students to postgraduate students to junior consultants, they do visit patients' home and keep the teaching doctor in touch, and they are doing it already. It started in US, and we have a habit of imitating US, and let us not question the value of it and importance of it. And I have no doubt it has to be done, and it's not whether you can do it or not do it, but we have to make it happen. And I think some of us who believe in it should go beyond institutional barriers, and I think we should meet together in private. Some of us come together and discuss this and make it happen as teams, multiple teams. And I think we'll have the whole community open for it. Thank you.
Sir, I agree with most of things what you said, sir. I have one question. It is a bit sensitive, but I will still bring it up. The question of money things. Yes, we all are patient-centered, and we do want to extend the continuity of care which has been started, and we want patients to get better. But as we equally understand that many of these things to happen and to make it grow bigger or to sustain it for longer term, we need to have a system in place. And for these systems in place, the manpower that you said in terms of technicians, paramedical staff, or all the arrangements that needs to be done, it probably does definitely involve a bit of a cost. And unless there is a specific channel where these costs are taken care, the program or the intention with which it has been started, I doubt whether it can be sustained for longer term or it can be grown large. So as Shankar sir was suggesting about the concept of EICUs which has been started, if we have to make these programs as the so-called home care delivery services, starting from maybe one hospital and building teams, if we have to seek, how can we make a system or monetize these things where at the one end we are not being greedy, trying to make business out of it, but at the same time the expenses that are needed to make this program sustain can be met without burdening the patients. What are your thoughts on these things?
Actually, it is sustainable. We have seen it earlier, and we are, except for this COVID times, there are some difficulties, but overall, it is sustainable. But be willing to share. the senior members of the team, one of the anomalies in medicine is that the senior members take away the largest proportion. They should be willing to share, and they should be willing to share with the whole team. And when it happens, the senior members practicing career and practicing years will be more and more, and they won't be losing. And I am telling from my personal experience, any of you won't be poor, but be willing to share with the whole team. And how you share and how to do that, I think at some point, those of you who believe in all this, we should meet together and happen. It need not be just senior consultants, right from doctors, nurses, physician assistants, students at various levels. All of us can meet, can get together and deliver this. When I say students, it's even medical students. Thank you.
Yes, sir. I get you what you're saying. I believe we should all meet sometime, come up with a protocol, and one of the Shark Tank will hear us, and this project, so to speak, does roll out, and we can provide better services. It is 8:02. So before we wrap up regarding this patient, coming from my point of view, so yes, as I was attached to this patient and the family, I did pay a visit, and so in fact I had to visit twice this patient with 3 days gap in between, and I could understand that his condition was deteriorating, and because what we realized is that he's requiring more of rehabilitative and nursing support than actual doctor services. And I tried to explain the patient, equally shared contacts from my friends and friends about providing nursing services and rehab services, and giving contacts from rehabilitation centers as well. So there were providers coming from home. I think he dragged on for another couple of weeks, and ultimately he succumbed. So regarding my share, so I've been part of home visits, I've been part of marriages, funerals, and many other things, maybe because I'm an emotional kind. None of the visits I charge, none of the patients I believe I can charge anything. I really don't know how far I can extend myself, but there are many situations which are uncomfortable, few being comfortable, but coming to the continuity of care, definitely valid. And I believe if we can all work together, put a system in place, and provide a kind of a model where these things can be extended to the needy, I think it's a long way to go. So before I take Anoop's final thoughts, any other person who want to share their thoughts? Well, if not, then maybe Anoop, your final comments and closing remarks.
Sir, can I speak something?
Yes.
So as Somaraju sir said, like, yes, of course, it is an interesting concept, but what happens is, like, doctors, they have their right to decide. But people like us, like, who are physician assistants, because we are working with an organization and we are always supposed to, report to somebody about our activities of work. So how do you think that we can be involved in this, such programs in much effective way? Because, the last patient that I was speaking, I ultimately had to, delay one of the visits, or had to cut off from one of the visits, because I wasn't given permission from the hospital to go around. And when I requested some other person, the higher authority, they said, we didn't appoint you for all this. So that is one biggest challenge that I feel, if we can be helped, I believe that there will be many people who would really like to come forward to do all this.
So Salma, I believe, yes. Yes, sir. Yes, sir.
What is the name?
Salma, sir.
Salma, thank you for bringing out. We are trying to develop a model or an institution of a kind where we work together as teams beyond institutional borders, and we may be working anywhere, but still we can do certain things together. And for that purpose, we have other issues also apart from this. medicine requires some transformation of some kind. The existing medicine is, as Shankar said, is dying. And to transform medicine, I think it's not doctors and nurses alone and everybody in the healthcare delivery system. And we'll meet together. For that meeting, we'll invite you also, please, many of you. And when we meet together, we can discuss some of this.
Sure, sir. Thank you so much.
Thank you.
Yeah, Anoop, your thoughts and final comments.
So I'll share a few things. Just like we have AFMC hospitals in the United States, they have Veteran Affairs or VA hospitals. The fundamental difference between VA hospital and the other hospitals in US is that in VA hospital, the provider and the payer both are the same, which means while the VA hospital provides the care, the cost actually comes out of Veteran Affairs budget as well. So it's something like if the cost of healthcare increases, then not only VA is actually providing the service, their budget, it takes out of their budget. So VA has an inherent interest to reduce healthcare cost as much as possible by providing the best quality care, because otherwise if they don't provide and if their patient doesn't die, if they continue to survive, then they are going to utilize far more healthcare resources. And VA has done multiple things which the conventional medicine structure do not do, but VA has done with the basic intention that the cost of care should come down. And some of these so-called continuity of care, VA has really become a role model in how it manages this transition that happens between the patient discharge and before the patient is up and running, up and about by himself or herself. And that transition VA manages by home care, by doctor's visit, and by pretty much every single thing, including providing grocery to the patient. Whatever patient needs, VA will do with the final intention that the patient should not seek any more health care for good reasoning, not because they are trying patient not to seek health care, but the need should not arrive. And need should not arise because at the end of the day, VA wants to save as much of cost as possible. This is totally different than the other model where the providers and the payers are typically different, like in US, which has got an insurance system where the care providers are the hospitals and payers are the insurance company. In India, we do have an insurance model, but most of our patients do have some sort of out-of-pocket expenditure. And when the expenditure comes from the patient's pocket directly, then we know what is happening in India, where patients do not seek healthcare. So I think US recognized what VA was doing. The US private healthcare structure, particularly the insurance structure, they also started reimbursing the home care because they realized that the money that they're spending in reimbursing the home care at the face of it seemed like they are adding cost, but effectively they were actually reducing cost because they were reducing rehospitalization, they were reducing need for other ancillary treatment and whatnot. And that certainly led to development of a very robust home healthcare network. US unfortunately do not work in a model that Somaraju sir is suggesting, where the healthcare delivery system works as a team, and one of the team member actually continues the care by making home visits. In US, the healthcare model is such that there is a home care model and there is an inpatient model. And while home care and inpatient, they do interact with each other, it is not the home care providers who are rounding on the patient when they're admitted inside, and also it is not the inpatient team who is going to the home to make a visit. In India, we can actually work on a model which what Dr. Somaraju is suggesting, where we develop a micro environment within ourselves which goes across the hospital borders. Not necessarily that only if hospital is providing the service, then only we do it. And we use some of our some of our team members expertise to extend these kind of services. And of course, we have to make sure that they are well paid for those services, whether we charge patient for that particular index hospitalization or not. We should extend the financial support to our team members in that regard. The way I see it is, and I thought I should implement this as a part of physiotherapy program, which for some reason has not been executed. You know, just like when you buy a new car, the first 5 services or 6 services or 3 services, whatever, are free. Just like you get admitted, 1 outpatient visit is for free. Now, can't we do something where these kind of patients who are admitted, we actually do provide them a home service for free, where somebody from the hospital, ideally from the treating group, by definition goes and makes a visit at home at day 3 or day 7 or whatever that the doctor determines, so that that service is existent, it is established within the system. And just like, you know, those free services are not actually free, you paid for that at the time when you are buying the car. Similarly, these services, they are not directly charged at the point of service, but they are charged much before that, so that even the financial implications are being taken care of, and they don't act as a healthcare burden to people. I think it is the right time, or in fact, we might be late to have such kind of service, because as Shankar sir was saying, that as he grew to become senior, he made less frequent visits to patients' home, and that is kind of the natural response. This is what I was telling early on, that senior doctors, they don't make home visits, not because they don't want to, but because they are busy. So the contrary to that is also true, that if you are making a home visit, that means you are not busy, that means you are not senior. I think that's the very basic essence of how community perceives us as a doctor. But if we have a team, and if we have a team member who acts as your extension, it may not necessarily be a bad idea. It may actually be a more workable idea than we ourselves making sporadic visits. And point is well taken, sir. I think this is something we should work upon and aim for a better outcome or better transition in this kind of care. On the long term, we need institutions like what has been discussed already. So there are patients who are homebound. There, the treating team cannot go every month and make a visit. So there we need institutes where we have got so-called home care institutes who makes periodic visits and who pretty much act as their regular care providers, with us as a specialist only acting on an as and when needed. That is the long-term assessment where I think institutions will play a big role. I don't think team dynamics can replace that institutional thing. If a patient gets discharged, like Praneeth, your patient, even if there is an active team in place and if you have a team member, I don't think we can provide a monthly or a twice a monthly visit to them for a long period of time. That is just not possible. Even if finances are involved, even then, for those we need institutional support or institutional framework, like some of the names which has been mentioned today. So that is what I had to close, Praneeth. If there is anything else you can add, otherwise.
Anoop,
Sir.
Sorry for interruption.
Sir.
We were doing it for more than 5 years, and during the COVID time, we had some difficulty because of change in institutional setup. We have some difficulties presently, but overall, for this purpose, those of you who believe in all this, you may not agree with 100% of what I talked about. How we can move forward, I think we'll call for a meeting. Those of you who are interested, we should meet together once.
Definitely, sir. Definitely. Any other questions and comments? If not, it's 8:15. So thank you all for joining for today's session and sharing your thoughts. And we definitely had a meaningful discussion for For every one of you, Weekly Huddle, we host every Wednesday, 7 p.m. The link is the same. We also have a WhatsApp group. The link is there in the invite as well. So it's where we do discuss offline and share comments. So feel free to join in. And until next time, thank you everyone and good night. Please take care.